Good afternoon. I'm Jurgen, your MC for today. On behalf of the Hong Kong Genome Institute, welcome to Gene Club, a platform for knowledge exchange and collaboration in genomic medicine. Today, we will explore sustainability within Hong Kong's genomic medicine ecosystem. It is my pleasure to introduce Professor Dong Dong, an interdisciplinary public health researcher and bioethicist at the JC School of Public Health and Primary Care at the Chinese University of Hong Kong. She is also a member of the Hong Kong Genome Institute's Ethics Advisory Committee. Professor Dong's research focuses on structurally marginalized populations in Hong Kong, China mainland, and other Asian contexts. She has published extensively in the areas of rare diseases, migrant and women's health, community health, and reproductive and genomic technologies. She is also the founder of the Rare Disease Real-World Data Lab, where she works closely with patient organizations to improve healthcare access and outcomes. She will be speaking on From Genomic Data to Health System Transformation, Building a Sustainable Genomic Medicine Ecosystem in Hong Kong. Please join me in welcoming Professor Dong Dong.
Thank you very much. Thank you, Brian. Thank you, Francis, for inviting me here. It's my first time to be in this institute. It has a very good view and also very young people sitting there. I feel the pressure of doing a good job because I don't want to everybody's spend their lunchtime and here. So my topic is a little bit big today, as far as I can see, because when we're talking about health system, especially the transformation of health system, probably everyone needs to know a little bit about the existing condition. Let's start with the definition. What is genomic medicine? I believe everyone here knows very well what is genomic medicine, but for the benefit of the audience, let's explain a little bit. Genomic medicine is a healthcare approach that uses individuals' genomic information to support disease prevention, diagnosis, and treatment. It starts with DNA sequencing. You're all very familiar with the process. Then you do genomic sequencing and analysis at different levels. Then you try to get a precise diagnosis on the disease that the patients might have, and then you prescribe personalized treatment. This is the common process of genomic medicine that all of us are very familiar with. However, genomic medicine is much more than that. If you think about it from a broader point of view, it's not simply about diagnosis and treatment. It is also about health outcomes. The reason why we want to get a diagnosis at genomic level is because we're expecting the patients can benefit more from this diagnosis and more precise treatment. And then at a more macro level, if we look at the healthcare system, by integrating genomic medicine into consideration, we can see that the entire healthcare system needs to be restructured by considering or including the needs and the outcomes that grow from the genomic medicine. So what do we mean by that? Let's take a look at some examples. The UK 100,000 Genome Project started about in 2012 or 2013. And it's very famous in the worldwide because it's one of the earliest pioneer program on genomic medicine. And they focus on rare disease and cancer at the pilot stage, and later they expand that to broader population. And we also know that in cancer diagnosis and treatment nowadays, it's very important to find a very precise gene mutation so the patients can benefit from different treatment options. EGFR mutation tests can help people to identify lung cancer more precisely and find specific targeted treatment. And also in pharmacogenomics, the genetic testing can support us to find better targeted genes so that medication safetiness and also medication efficacy can be largely improved. Take a deeper look at the UK 100,000 Genome Project. In the pilot study, which was published in 2021, they analyzed about 2,183 patients with the long-term undiagnosed rare disease, and they also do the analysis and find and provide genetic diagnosis for approximately 1/4 of these patients. And among these patients, it's about like 500 patients. 86% of the diagnosis was completed through automated analysis pipeline. That means it saves time and human power, right? And then only 14 required further research and analysis. So the infrastructure itself works very well in this case, because when we think about genome testing or whole genome sequencing in the ancient times, it involves lots of human labors. So it's a very labor-intensive work. However, starting from the UK 100,000 genome pilot, they use automated analysis pipeline to do that. And by analyzing these more than 2,000 patients, they discovered 3 new disease-causing genes and 19 new disease gene association. So at least 500 patients got to know like what they have, and hopefully they can find certain treatment for their diseases. And this is the most updated data from the 1000K genome project from UK. We can compare the results. Only 5 years later, you can see the number of their cohort has been greatly expanded. Now there are nearly 100,000. It's 90,000 unique participants from, and also with their clinical records. That means those people not only contributing their genes, but also contributing their clinical history to this project. And they have identified or involved more than 70,000 nearly 80,000 rare diseases, and also nearly 18,000 cancer patients. And now they involve different kind of sequencing technologies there and try to identify more diseases. So more families have been benefited from this project. Now nearly 35,000 families, they issued, or they find tier 1 and 2 and 3 variants, and many other can have a more precise and timely diagnosis. And in total, like shifting from 3 novel disease genes in like 5 years ago, now they find 141 brand new disease gene association. So the patients and their family greatly benefit from this project. So by looking at that, this is just one case from UK, and you can see that genomic medicine is not just about diagnosis. Actually, it provides answers to the families, especially those families who is trying to find answers for so long. And also, it drives efficient healthcare resource allocation. That means we don't need to spend much time on finding answers. By using genomic medicine and genome sequencing, we can shorten the diagnosis time and provide more precise answers to those families. Let's take a look at some examples. These examples are real-world example. It's been published somewhere. So the first case, there is a 10-year-old girl who experienced a 7-year diagnostic odyssey. Diagnostic odyssey is a term used for a long time in the rare disease patients community, because many of them need to experience a very long time odyssey to get a diagnosis. So the girl experienced 7-year diagnostic odyssey before being diagnosed, during which she had 307 hospital visits. Can you imagine a 10-year-old girl nearly spent half of her life between all these hospitals? And then she also received multiple intensive care treatment due to her condition. So the overall healthcare costs accumulatively is more than 350,000 pounds. Then they use whole genome sequencing, try to find out why the girl is sick. She then was identified the cause of her illness. Then she received a bone marrow transplant. The cost is approximately 70,000 pounds, and then she was cured. So you compare all these numbers. If she could use genome sequencing earlier, how much money the healthcare system can save, and how much painful experience the family can be waived. So early genetic diagnosis can prevent long-term expensive and ineffective medical investigation. And this case just to illustrate that. A second case, This is an old guy in his 60s, and he has undergone years of treatment and 2 kidney transplants due to severe kidney diseases. Nobody knows why that is. And you think about organ transplant, it's not just about the cost. It's also about it's a very scarce resource, and not so many people are lucky enough to get that. So again, through the Genome Project, he got a whole genome analysis and identified the underlying cause. It's an inherited genetic disease. He has a daughter and a granddaughter. So fortunately, his granddaughter went through this genetic testing and was confirmed that she was not having this gene. So she doesn't need to be monitored anymore. Like when we find something running in the family, most of the time we need to test and follow the family members closely. That also can be quite costly. So the genetic diagnosis can also avoid unnecessary medical surveillance and clinical expenditures. It can help us save money again. And the last case, there is this newborn baby, and I think in Hong Kong nowadays, lots of newborns have gone through newborn screening test. This is a similar case. However, the baby became very ill right after birth and passed away 4 months later. So approximately the cost for the healthcare system is about £80,000, but the baby was not diagnosed. With whole genome analysis with the baby and also his families, they find a metabolic disorder. And then they also know the reason why. So by having this more precise diagnosis, the younger brother of the baby was also tested and diagnosed within a week of birth. That means the baby can have treatment immediately, so the baby can live more healthfully throughout his life. So genetic diagnosis can facilitate early intervention and avoid future healthcare costs. So these 3 examples, you might be very familiar with the scenario since you have been working for the Hong Kong Genome Project for a while. However, think about it. It's how do we using a healthcare system perspective to understand the situation. So when we think about genomic medicine, of course it involves diagnosis, treatment. Of course it involves certain costs from our system. However, it impacts is more than that. It's just not just on the individual diagnosis and care, and it can reshape our healthcare ecosystem policy framework. I'm going to look at our neighbor, Singapore, and to explain why. In Singapore, they have this PRECISE project, which exactly is about precision medicine and precision public health system. So it started in 2017. It now has 3 phases. So the first phase is the phase called proof of concept. What they're trying to do is to create a Singapore 10K health database. So they conducted whole genome sequencing with 10,000 Singaporean residents. And they map out the genetic variants that is unique to Asian population. And we all know that in Singapore, there are very diverse ethnic groups living there. So they formulate the baseline, trying to estimate the genetic disease burden of the local population. So they have finished that. Then in the second phase, they just finished it. It was between 2020 and 2025. It's called proof of value. So what they're trying to tell the founder, the government, and the public is that direct clinical and public health value of precision medicine. So what they did is to establish the precise Singapore 100K cohort. Now they expand from 10K to 100K. They conducted whole genome sequencing with 100,000 local residents. And they tried to create a more comprehensive genomic profiles, phenotype database, and electronic health records to integrate the health records with the genomic profile. Then they developed the trust. It's called Trusted Research and Real-World Data Utilization Sharing National Health Data Platform. So clinicians and also the public health professionals, they can access to this data platform. When they have people who find certain diseases or symptoms, they can use the database to compare and to find out which kind of treatment or care they can provide to their patients. Okay. Now they're moving into the third phase. So the third phase is the proof of implementation. Data here is a little bit outdated because I just saw another presentation from Precise. They actually are trying to recruit and sequencing 1 million patients from Singapore, considering, how the population size of Singapore, right, is 6.5 million. So it's 1/5 of their residents will be having whole genome sequencing. So it's about more than 10% of the local population. And they shifted from creating database. They are trying to focus on the population health. So what they're trying to do is to partner with Singapore's 3 public healthcare clusters, SingHealth, NHC, and NUHS, to set up genomic innovation hubs. So they're trying to connect genomic sequencing results with the daily e-health system and trying to see how the entire population in Singapore can benefit from precision medicine and also whole genome sequencing. So you can see when Singaporean is doing things, they're doing things very clearly and step by step, very strategically. So this is not just happening in Singapore. All over the world, many governments worldwide, they utilize public funding to start this investment in precision medicine and genomic medicine. The investment usually focuses on 3 things. One is genomic data infrastructure, like you're creating a database and you're trying to get lots of investment in sequencing itself and technology itself. And then you also consider how to apply this genomic data to clinical setting. And then the next step is to think about biomedical innovation, like how you can use the data by connecting genomic level of data to the clinical level of data and how you can use those. So genomic medicine is gradually and increasingly integrated to national level health and technology strategies. Here is a map that we can find the major players in the field. So United States, it has this All of Us research program, and the total investment, now I don't think the Donald Trump government is doing anything there, but in the past, they have overall 1.46 billion US dollars into this research program. In the UK, for the 100,000 genome projects, the overall investment is 0.85 billion US dollars. You can see Singapore, right? I only show the most updated data here because that was clearly stated in their government documents. It says the Precision Health Research Singapore will receive 1.9 billion US dollars for 5 years to support the third phase of their PRECISE project. And in mainland China, starting in 2017, 2018, Chinese government has invested a large amount of money, overall 9.2 billion US dollars into precision medicine initiative. And in Hong Kong, the Genome Project has only 0.15 billion US dollars. And you have done a lot. So the key challenging is to see how do we build a policy and funding frameworks that can make genomic medicine more sustainable in the long run. It's not just about money, it's about mentality as well, how people understand and have this vision of the future of genomic medicine and why it is connected to every one of us. So we will talk more about that. In theory, we think genomic medicine ecosystem requires people to think the entire health system infrastructure in a new way. Because genomic medicine rely heavily on large-scale genomic database, bioinformatics analysis platform, and electronic health record system. Hong Kong has some, but we don't have all of them. And all of this needs to be seamlessly integrated with the data infrastructure of the current healthcare system. So it's not just about technological revolution, it is also about the entire design. How do we think about things or visualize things in the next 10, 20, or even 5 decades, what's going to be happening there? Then we need to invest everything in advance. And also research indicates that the clinical translation of genomic medicine frequently requires a comprehensive redesign of the healthcare system, especially the data and information architecture. And then the ecosystem also requires medical service and clinical governance framework to be revised and modified. That is because when we integrate genetic testing into routine medical services, you can think about how do we have enough clinical geneticists. Brian is the first clinical geneticist in Hong Kong, right? If I don't remember it wrongly. Because we don't have manpower, we don't have sufficiently trained professionals in Hong Kong who can help the patients interpret the results of genomic sequencing. And how do we make sure the quality management and multidisciplinary collaboration in this field? You think about when you have a patient walking into your clinic, and the patient has done a whole genome sequencing, and based on the report, you find some issues there. However, trying to give a diagnosis is more than just reading the sequencing results. It also involves interpretation. And when we have interpretation, it's not simply about solid scientific test. It involves human interaction, which kind of language we use, whether the language you use, the patients can understand, the psychological reaction to the diagnosis. How do we make sure the patients can bear with those kind of unusual, uncommon diagnostic results? So we need to involve social worker, we need to involve psychologists, we need to find out social resources for these patients so that they can get help from somewhere, because many of those diseases still we don't have any treatment. So this is not just about clinical, it's not just about medicine, it's about people from different areas, how we can work together. So we need to create a systematic governance and organizational structure so that the clinical application of genomic medicine can be more equitable and also not so fragmented. And third, we also need to require support from health economics and reimbursement system. In Hong Kong, we have universal health care. Many of us use public hospitals or public health care resources to deal with our issues, health issues. However, by involving genetic testing or genomic medicine, the cost to the public health care system will be greatly elevated. Are we ready? As taxpayers, are you ready to pay more tax for doing that? And I think there's lots of literacy issues as well. Many of us don't understand the importance of having genomic medicine or precise diagnosis. Many of us think I just have diabetes or hypertension. I use the drugs that I have. It can control. Why do I need to do a genetic testing? But later you will see that many of those better treatment actually should be targeted treatment and can help you improve your health more efficiently. And last but not least, it's about public health and equity policies. When we think about genomic medicine, we always think who can benefit earlier or more from the system. Usually it's the rich part of our society, right? Many years ago, when the genomic sequencing technologies just to get started, lots of rich people, they are thinking that we just do some sequencing and try to make sure I can prevent certain diseases. And also think about designer baby. If you are familiar with the concept, people trying to have a perfect baby nowadays, because before they are conceived with the baby, they can do genomic testing on the embryo so that they can find a perfect embryo to be implanted into mommy's womb so they can get a perfect baby with certain talented genes. So genomic medicine, like all new technologies, it inevitably will bring in equity to our society. How should we deal with that? Can we create a more equalized system so everybody can benefit from it in a more ethical way? And then money. Money is something that we have to talk about, even though personally I'm not good at money at all. So the economic value and cost effectiveness of genomic medicine is something that we are trying to elaborate and persuade the policymakers to think more about it. On the one hand, we think the economic value of genomic sequencing is very important because there is this very recent systematic review. It identifies 130 economic evaluation of whole genome sequencing and whole exome sequencing, and they find the cost actually is quite limited because the cost usually happen at an infrastructure level. For example, the technology itself, bioinformatics analysis, how do you interpret the variants, and also genetic counseling. That's the price you pay for counseling service. However, the benefits is much more. In the immediate clinical benefits, you can have earlier diagnosis, higher diagnostic yield. You can reduce unnecessary testing and also associated anxiety to all these testings. And you can provide more targeted treatment to the patients. Even the treatment is the same based on genomics, you actually can consider different options and which one is more efficient than the other treatment options. And in the long run, the economic benefits can be even larger because it can use the healthcare utilization. Think about the 3 cases I shared. If all the patients can get a more precise diagnosis at the very beginning, their families or other kind of care may not be needed for them, and they may consider to have other options which can lower the healthcare utilization. And in the long term, it can prevent complications. Disease prevention is something that genomic medicine can contribute vastly in the future. It can lower lifetime cost and also improve health outcomes. So we think about the benefits or the value of genomic sequencing, it is more than just invest in the infrastructure or having diagnosis or treatment. Actually, at the level of disease prevention and health outcomes, it can play a bigger role. So now we have very strong evidence on the cost effectiveness in the following area based on this comprehensive review: rare disease diagnosis, hereditary cancer risk assessment, selected precision oncology applications with actionable biomarkers, and genomic guided prescribing. In these 4 areas, already the existing literature has shown very strong evidence that it can be very cost effective. So the economic value is the greatest when the genomic testing lead to actionable clinical decisions for nowadays, because we have limited plans or strategies when we find out certain diagnoses. And then, on the other hand, we want to look at the treatment itself. I think you're all familiar with the concept of gene therapy, right? Gene therapy is becoming more and more popular and fashionable nowadays, but it actually can save patients' life. This is Dr. Sophia Chen from the Children's Hospital and also Queen Mary Hospital. She is a pediatric neurologist. She has done at least 2 gene therapy among rare disease patients in Hong Kong. One is for spinal muscular atrophy patients, and the other is for Duchenne muscular atrophy, DMD dystrophy patients. So she was trying to help the patients there because in the past, those young kids, when they were born, they suffer from all these issues. And sometimes SMA patients, if you're unlucky, you're type 1 or type 2, you cannot live until after your teenage years. So Dr. Sophia Chen has conducted these trials of gene therapy in Hong Kong. However, we need to prove that gene therapy is cost effective because it's really very expensive. Like, for example, the treatment for SMA, it costs more than $2 million per person. Okay. And then this is a father from mainland China. His name is Xu Wei. His son has Menkes syndrome. Menkes syndrome is a metabolic issue, but there's no cure, no treatment at all. What he's trying to do is to find some chemical compounds and mix them up in his garage and provide certain treatment to his son. Of course, it's not working very well. So later, his story was publicized in the media. There's some companies trying to help him and find a gene therapy just for this baby. So it's like an N of 1 kind of therapy. So they try it on the baby. We don't know the outcome yet, but at least for the rare disease community, they start to have hope because now they find out there is this availability of gene therapy that their kids might be able to use. Here is a group of mothers with their children with MPS. So they actually, all these kids, they have different subtypes of MPS. And they have this foundation and raised about 1 million RMB to find a gene therapy for their kids. Of course, 1 million RMB is not enough because to develop a gene therapy for a certain disease, it costs more. But the point here is we want to prove gene therapy is something effective to treat the patients, but also can elevate the quality of life among the patients. But then if we use the traditional cost effectiveness analysis to this, the equation doesn't sort of work out here very well. Because if you look at the equation here, ICER, incremental cost effectiveness ratio, usually they want to compare the cost of existing treatment to the cost of new treatment, and they want to use QALY, the quality adjusted life year, as a comparison point. So how do you decide which QALY, like how much you want to pay to improve one QALY among the patients? Usually it's based on the general population's willingness to pay. So for every society in the entire world, the money that the taxpayers or the residents in certain society, they are willing to pay for certain treatment varies a lot. It's related to that specific society's socio-economic status. So, but no matter what, when we're trying to calculate the cost effectiveness of gene therapy, it's not cost effective. And no taxpayers in any country want to pay that much money. I'll give you a deeper look at that. This is a study about SMA type 1 patients, and they're comparing 3 treatment strategies for the infants with SMA type 1. That's the most severe type. So the standard cost of standard care, actually there's no therapy, so the patients only needs to have supportive care, ventilation or some nutritional support or some intensive care provided by the caregivers. Nusinersen, that's the first like disease-modified therapy for SMA. It was also available in Hong Kong. However, the cost is about $0.75 million every year. It's a lifelong treatment. You can calculate with the support of this treatment, the patients may live like 20 or 30 years longer. So the prices can be very high. Then Zolgensma, this is the first gene therapy available for SMA. It's a one-time use, but the cost is $2 million US. So based on a study conducted in Australia, Zolgensma, they're trying to prove that Zolgensma, the gene therapy, is cost effective. So Zolgensma actually can generate 2.2 QALY at an incremental cost of Australian $4.11 million versus no care at all. It can yield 1.8 million per QALY compared to other treatments, and it's far above the willingness to pay threshold. So in Australia, it's 50,000 per QALY. That is the amount of money everyone is willing to pay if we can have one QALY improvement of the patient's life. So therefore, the result is not cost effective. And if you're a policymaker, when you see these results, the decision is not difficult to make, right? Because it's not cost effective, we shouldn't use taxpayers' money to do that, so it shouldn't be included in the public healthcare system. But how about if we start with newborn screening? Like you start with the treatment earlier, the patient's prognosis will be much better than you start the treatment like later. So there is a number of research conducted in different countries in the world. They're trying to say the cost effectiveness of newborn screening for spinal muscular atrophy patients. So the results varies a lot. As I told you, like the calculation of cost effectiveness also relying on the willingness to pay for each society. So the results varies a lot, but in summary, it shows that from these 6 countries, newborn screening facilitates earlier initiation of disease-modifying therapy for SMA, leading to significantly greater health gains and, in many cases, lower overall healthcare costs. However, the cost effectiveness still remains highly sensitive to the treatment price and willingness to pay threshold. Again, how much the general public wants to pay. I think now you see who are the key players in the entire game. It's not just about the scientists, the clinicians. It's about policymakers, and it's about all of us who is sitting here, who has no suffering, no contact with rare disease or genetic issues, but it's up to us to decide whether we want to pay for that. We want to convince you that the value of genomic medicine is not just about testing or treatment alone. It can optimize outcomes across entire patient's journey. So when you take a look at this graph again, you can see that when we start with DNA sampling, we do genomic sequencing analysis, we provide precise diagnosis and personalized treatment to the patient, we can improve their health outcomes, and then we can feedback all the information we collected throughout this process to our healthcare system, then we can convince everyone it's worth it. So genomic medicine is an ecosystem. It's not just about technology itself. The value is created across the entire pathway, from testing to diagnosis to treatment and long-term outcomes. And individual components, like for now, the gene therapy seems to be only helping individuals. The individual components for all these processes can be costly, but the integrated system can generate more substantial health and economic benefits. So we need to consider how to make the implementation of genomic medicine more sustainable. It requires supportive, like financing, infrastructure, and equitable process. So we need to evaluate the benefits for the entire ecosystem, not just for individual patients. So how do we do that? What Hong Kong needs? Coming back to Hong Kong, we want to think about whether Hong Kong can benefit or Hong Kong is able to build such a sustainable genomic medicine ecosystem. This is the data that I believe all of you are very familiar with. I got this from the annual report, and also thanks to the team, they share with me the most updated information. So starting from a Hong Kong Genome Project is very young in the field, right? You only started in 2021, and you have achieved a lot in the past 5 years. You have recruited more than 60,000 patients. You have enrolled more than 44,000 families. You have the initial target is only 40,000 to 50,000. You have achieved far beyond that number of people, and also ahead of schedule. And 88.2% of the patients already received optimized treatment, or they can following their genomic findings. So it's Hong Kong Genome Project. Unlike many other pilot projects in different countries, you started from day one, not just to accumulate data, but you have already shifted to the clinical impact and trying to integrate the genomic sequencing data to clinical usage. And this is the article. Congratulations. Your team just published in Nature Medicine. So you also find out that the Chinese population is underrepresented in the genomic research worldwide. And we also know that this is also about equity issues. Worldwide, when other countries started to do their own genomic sequencing project, they only focus on their local population. And who are the countries who can do that first? UK, US, more advanced or more developed countries. And the major population there are Caucasians or other ethnicities, but not Chinese. Even in Singapore, Chinese is one of the 3 major ethnic minority or majority groups living there, Chinese, Indian, and also Malay. So in Hong Kong, 95% of the local population are Chinese. I think by having this project, you have identified something very unique to the local population, which I'm going to show here. Brian also shared with our committee last time in the EAB meeting. I was very impressed. I was very impressed by one thing, that is the cardiovascular gene here. The cardiovascular gene were markedly high in the Hong Kong Genome Project Chinese population. They inform adult cardiology genetic testing and familial hypercholesterolemia testing. FH, actually, that particular gene affecting the Chinese population more than other ethnicities. And think about what are the biggest issues in Hong Kong nowadays: aging population, chronic disease, diabetes, high cholesterol level, hypertension. All these cardiovascular issues are related probably to the gene. By knowing that, the entire government or our healthcare system may have new thinking and new thoughts, like how do we deal with that? So this finding actually will bring in more long-term impact on our healthcare system. But Hong Kong, we all know we have lots of challenges here nowadays, because most of us, like more than half of us, use the public funding to support our healthcare system. And our primary healthcare system accounts for nearly 30% of healthcare expenditures, and the total health expenditures is about 8.3 of the entire GDP in Hong Kong. And we face a rapidly aging population, growing demand for chronic disease management and long-term care, and healthcare spending remains concentrated in hospital-based secondary and tertiary care, especially with the public sector. So genomic medicine and other innovative health technologies may increase short-term cost, but in the long run, it's going to help alleviate the burden of the healthcare system. Why is that? There are three persons, you may also familiar with their faces. They are illustrated in the latest annual report. I read through them. I was very impressed by the experience shared. So these three scientists and clinicians, what they focus on not rare diseases. They are focusing on something quite common in the general population, and they prove that by using genomic medicine and genomic sequencing, they can help patients with earlier diagnosis, early prevention, targeted treatment, and then can improve their general health outcomes. So the key still here is about the ability for genomic medicine to diagnose and provide intervention earlier. It can provide more precise and effective intervention. It can also prevent avoidable complications, better use of the healthcare resources, and then improve long-term health outcomes. So these examples, along with other many examples that's shown from Hong Kong Genome Program's annual report, they show that genomic medicine is not just for rare disease. It actually can help all of us. So how do we do that? I think, first of all, when we look at our investment or the cost for genomic medicine, we think about the medical technology itself. Of course, we need to invest in medical innovation and all different types of technologies. However, the medical innovation itself can be a driver of healthcare spending growth. That means more people are willing to spend money on that, and more technology or the investment venture can do things or trying to bring more resources to this field. And it can have higher spending cost, however, it doesn't mean lower value. That means more money, but we have much better results. So the investment is worth it. And the goal for us to consider the effectiveness or the cost effectiveness of genomic medicine is not to focus on the cost itself, but trying to focus on the value that it can bring to all of us. So I'm thinking, ask not whether we can afford genomic medicine, but we need to ask how genomic medicine can create the greatest value for patients, the healthcare system, and our society. So this is the 4-tier of health disease prevention in public health. For those who doesn't have public health background, I explain a little bit more. So we don't simply focusing on primary, secondary, or tertiary prevention. Nowadays, we also focus on primordial prevention. That is to reduce population level disease risk before risk factors emerge. So at all these 4 different levels, genomic medicine can play a role. Like starting from very early days, when we know that the Hong Kong Chinese population have a higher risk with cardiovascular diseases, what can we do? We bring in lifestyle intervention. We tell people about it. We ask people to take care more about their own life and their diets and their exercise so that they do not need to have this gene being expressed, become a disease in the future. Primary care, we do screening tests. We try to find out more risks faced by the population so we can tell people more information about the risks they are facing so that they can have more informed decision making. At the secondary level, we detect the disease earlier so we can provide better care sooner. And then the tertiary level, we can improve the outcomes. Think about pharmacogenomics, right? We can provide more precise treatment to the patients so they can have safer and better treatment. So from genomic data to health system transformation, this is the value chain we are trying to talk about. The first or the underlying level of this value chain framework is the genomic data and infrastructure. I have talked a lot about that today. And above that, we need to have the clinical integration and workforce development. That is, we need to have manpower. We need to have professionals with sufficient training in this field. We need to have people from multidisciplinary background so that we can establish a more solid foundation for genomic medicine. We need to think about precision therapy and innovation. Once we find out what the diseases are and what the root cause of all these diseases, we need to have solutions. We need to provide answers, better answers to our patients. And when we evaluate all of these, we don't simply focusing on the cost itself. We look at outcomes, the evidence, and how do we build in or trying to feedback all these outcome and evidence back to the system to tell people we need to create a more sustainable and a more effective ecosystem for us. And then in the last, we need to consider the governance structure, the financing system, and how can we make sure equity can be ensured throughout the entire genomic medicine field. So that concludes my presentation today, and I will be happy to take questions. Thank you.
Thank you, Professor Dong, for the insightful presentation. We will now open the floor for questions. Participants joining us online are welcome to submit your questions through the chat function, and those here in the room may raise your hand.
Professor Dong, thank you very much. I have always been a clinician, and as a clinician, we diagnose and treat individual patients. And I know you have a very strong public health background. And now you have given us a very good demonstration of how you are diagnosing and maybe treating the entire population. This is great presentation. And of course, the one slide that I like most is the world map, showing us using the least amount of money and was able to do a lot of work. And I always know that what we are doing here in the Institute is very meaningful. But today, you're bringing the meaningfulness into another level. Now I see the entire picture, and this gives us more initiation to do good work. My specific questions is really on the new understanding that you have given us on the value of newborn screening. And I'm, of course, very interested in the latest technology, newborn genome sequencing as a screening. Because by screening SMA and know the disease at a much earlier age, you only not help the patient, but you also help the healthcare system to make the entire journey of a patient with a spinal muscular atrophy, even with gene therapy, to be much cost effective. So I can see that, and I want to hear your advice on that. If we're able to screen more than just one condition using genome sequencing in newborn, maybe it's actually helping to bring down the cost or improving the cost effectiveness of many gene therapies or many advanced therapeutics all at one go. Do you have a thought on that, please?
This is a very good question. Thank you, Brian. I think before we answer that, we need to deal with certain assumptions. Because when we do newborn screening test, we assume we have treatments. But many of the genetic issues faced by newborns, we don't have any answers to that. So I think, ethically speaking, when you were thinking about providing answers to the families, then you need to think about which kind of answers you are able to provide. For SMA patient or for some other metabolic like disease, newborn disease patients, there might be answers. You can use, like for metabolic diseases, you can use special dietary food or other things to deal with that. So the quality of the patient's life can be greatly improved. And actually the kids doesn't look like patients at all. They can live a normal life. They are perfectly healthy. In mainland China, there was this young girl who was born in the US who was lucky enough being the first cohort to get the gene therapy. And she lives like a normal kid. She can run, she can sing, she can do everything she wants to do. So I think first of all, we need to deal with the assumption. So if we are able to provide treatment or answers to the family, we should go for it. Okay? Then when we provide answers or when we promote newborn screening, we also need to not simply think about, like, for health economics or from the government's perspective, they always focus on how expensive the treatment can be, $2 million US. Then, like, when you calculate the value, you do not simply focusing on this patient only. You include her entire family. Like for any spinal muscular atrophy family, when we observe in many countries, usually one of the two parents have to become full-time dad or full-time mom. They cannot produce or do any work because the patient needs 24-hour care. Okay? So if the patients got cured by using gene therapy, both parents can go back to their work setting. They do not need to hire anybody. They do not need to send the kids to use public health system all the time. They just need to monitor the kids. So the entire cost actually becomes much lower. You're considering nowadays, even without treatment, the SMA patient can live or survive for more than 10 years. So overall, of all these 10 years, how many costs we can lower? And then the parents, they can contribute more. And also the patient themselves, when they grow up, they might be very talented. They might be very innovative. They might bring in more social benefits to all of us. You never know. So in that understanding, the value itself is not just about individuals. It's about the future. How do you think about the value we can create to others from our society? So the value calculation or how to assess the cost effectiveness of gene therapy needs to be totally modified, revised in our society. I think many health economists, they are working on it, but so far we don't have an answer to that. If we can solve that problem, we can persuade the government, like newborn screening can bring more benefits, not just for the patients, but also for the entire system as well.
Thank you, Professor Dong, for the really inspiring talk. It gives us a brand new angle to assess what the value of our job. And talking about the evaluation of the genetic therapy, I actually have a follow-up question regarding on how we evaluate, because one very important element in the formula is the cost. And we all know that the therapy are expensive because they are very difficult to be developed. But with the recent advance in genomic medicine and all the advance in technology, we all know that you also mentioned N of 1. Do you think that the strategy that the administrative government, maybe the governments that used to develop drugs for rare diseases, like they maybe have orphan drug designation, they may have a fast track pathway for these drugs. If those are those formulas or existing pathways enough to solve the problems we now face in the N of 1 or in the personalized medicine era, or do we really need maybe another other measures to really to lower the cost of the therapy themselves?
Yeah, if I understand your question more correctly, you are asking, like nowadays, the gene therapy just for a very small group of people, because sometimes it's developed just for one patient. And then how other patients can benefit from that. Am I right?
Yes, and do you think, I'm not quite sure, but if like from your point of view, are existing like maybe the governance in about regulating the development, because they are really, those regulations are designed for drugs maybe in from the past, that maybe they are chemical drugs, but and other, those types of drugs, are they still like enough to drive the development of genetic therapy?
Of course not. So we still know very little about the long-term outcome for all the therapy, honestly speaking. So even for Zolgensma, right, it's only been around for about 5 to 6 years. We don't know, like in 10 years or 20 years, what are the long-term consequences or outcome for the patients. I think in regulation side, in the from the policy side, there's lots of new things we need to learn. That's very sure about. We are very sure about it. But even by thinking thinking about it, like the development or the evolution of science and technology tells us that we don't stay with or within this very comfortable zone, because we need to have breakthroughs. And all the breakthroughs started from very small amount of people. Like if you are familiar with rare disease, you know that the Orphan Drug Act in the US started in 1983. And with that, it's not just about rare disease patients, because all the patents, all the innovative technologies developed from Orphan Drug Act and also rare disease now can be applied to the general population. Okay, so it's never been about a small amount of people, but everybody can benefit from that. So I think this is a parallel process. On the one hand, we shouldn't say that it's just to benefit one or a group of patients. We shouldn't do that. We need to have the vision that in the future, in next 10, 20, or 50 years, everybody will benefit from that. And by accumulating experience based on this small group of people, we can reconsider the regulatory framework, the policies, and everything get involved, so that we can provide more ethically and politically safe kind of policy to everyone.
Thank you, Professor Dong. It's very impressive. And I see you talk about a lot of the benefits, economics of doing the sequencing, precision medicine, on the genomic medicine. But we see some comments because, for example, in our Nature Medicine paper, we published that more than 1% of people are carrying cancer risk mutations, so which means they will have higher risk in their entire life for cancer. But it may, so they will visit the healthcare system to do more screening or other follow-ups. So it may increase burden for the healthcare system. And do you think this will be, how can we understand, because it says should be a negative side for the healthcare system, maybe they will have a lot of workload to be handled. What's your comments on this?
Okay, that's a typical question. I can understand why a reviewer asked that. So it depends on how you think about the cost. Like, which cost more? To do screening test versus to give targeted therapy later in their life, which cost more? Definitely, provide treatment will be more costly, because during the process, without knowing they have higher risks, they may not pay attention to their lifestyle. It's highly more likely for them to eventually develop to having symptoms or the disease itself. So that will create even bigger burden on the system. And then you think about their family. Once a patient have this genomic diagnosis, the entire family will benefit from that. Of course, different people have different choices, right? Some people wants to know, some people doesn't want to know. For those who is willing to know, they will start to take care of themselves earlier, so that can lower their risks of having the disease. So overall, I think prevention, like by including the genomic sequencing as a preventive strategy, can lower the cost to the system overall.
If there are no further questions, we will conclude today's session. Professor Dong, thank you once again for your enlightening presentation and for sharing your valuable insights with us. We have certainly gained a deeper understanding of sustainability within Hong Kong's genomic medicine ecosystem. Thank you all for your active participation, both online and here with us today. We look forward to welcome you to our next Gene Club session, and stay tuned for upcoming events.